about diagnostic radiologists. That's the mostly non-patient facing radiologists, that CMS term, the administrators out there, right? And then versus the interventional, which are mostly patient facing, although not always radiologists, right? We kind of came up with a third term, which is the preventional radiologist, right? And we think that this is where one of the things that we wanted to end with is that preventional is identifying things that people are at risk for that it wasn't ordered for, right? So a word we're starting to use in the American College of Radiology is, as we start to try to measure impact. We talked a lot about the patient-facing part, Jason, earlier, but whether it's patient-facing or not, one of the things that we could do as radiologists on this preventional aspect is on a film that's, as CMS uses the term, reason for encounter or reason for exam, right? That's their term. Is that maybe something that wasn't in the reason for exam, we find something they're more likely to die of in the next 10 years. Like they might be negative for the tumor in the lungs or the abdomen, but guess what? We found severe coronary calcifications, right, on that. And optimizing the workflow that we, not just the radiologists, which some were trained not to even mention it, by the way, many years ago, right? Now we mention it on these CT scans. More than mention it, put in the impression and say, let's weaponize that and make sure that patient gets to a cardiologist. So now it requires radiology to work with cardiology, cardiovascular medicine, et cetera, diabetes teams, et cetera, making sure these patients get back to their primary doctor faster and getting a dedicated workup for that condition. Another one that we think is coming down the road is arterial calcifications on mammography. Much larger chance of being one of their leading causes of death in the next 10 years if we find that incidentally on a routine mammogram. So John, I'll turn it over to you, but I think those are just some of the many possible examples of us being preventionalists, but those will, when we adopt that role, Jason, it will force us to develop, as we said earlier, workflows and some more patient-facing aspects, if not me, the radiologist myself, perhaps the HI that works with me, which are the various other people he's discussed in the cycle, advanced providers, RPAs, APPs, APRNs, et cetera. And so I think how you develop that workflow as a radiologist, how you oversee that rather than be a catalyst, in other words, and not just be we don't want to become commoditized and become a victim, right? So how we kind of take ownership in that in our system and really engage the other leaders and the other services and the administrators and develop ROIs for the value streams that we're creating, like cardiovascular medicine as the example I just used, and like breast oncology as I just used an example. Developing those values together also articulates the system so we can get that buy-in and the resourcing to pay for the human intervention that we think needs to happen. So that is, that becoming a preventionalist is an investment.